All right. Again, good morning and happy National Rural Health Day. My name is Danae Aber. I'm the Executive Director of the Louisiana Rural Health Association. With me, I have Zach Snyder, who's our policy analyst. And we're also happy to have Tracy Ingram, who's a consultant with the State Office of Rural Health, who's helping to co-host the event with us today. She's going to be in charge of monitoring the chat to make sure we catch all of your comments and questions. So I'm going to quickly go through the agenda we have for today. So we will review some recent regulatory updates, specifically the physician fee schedule, the outpatient prospective payment system, and the new HHS non-discrimination rule changes. And then we'll talk about some potential health policy priorities with the new incoming administration. We'll touch on those really quickly. Um, and then we'll go over some needs and challenges that we identified in a recent provider survey that LRHA conducted. And we'll give you guys the opportunity to provide any feedback, give us some additional information on the challenges and how they're impacting your facility. And then we'll end on a positive note by giving you guys the opportunity to share maybe some wins from 2024 and any exciting plans you guys have on the horizon for 2025. And so with that, I'm actually going to hand off to Zach to get started with our regulatory updates.
Great. Thank you, Danae. And I am really happy to be here today. So my name is Zach Snyder. I am the policy analyst with LRHA. I've been with the association for 3 years. I enjoy working with providers, helping them understand the laws and policies that will impact their ability to provide care to our residents and help to take their voice and advocate for change when necessary as well. That's something I really enjoy. So, like Danae said, we are going to talk about a selection of regulations today. We could take this in a lot of different directions in terms of proposed legislation at the state level, legislation that passed at the federal level, state level. We decided today to really focus on some, pretty large rules that CMS has enacted at the federal level as just a sampling of, some of the large healthcare issues or rather health policy issues that are impacting providers. And so, like Danae said, the three rules that we're going to cover today are the OPPS rule, so the outpatient prospective payment system rule, the physician fee schedule rule, and the non-discrimination rule. So the first two are actually annual rules. So these are rules that CMS will annually update that really impact how much providers get paid. And so we know that that's a major issue. And that is, if not the most, one of the most important factors when it comes to access to care is that reimbursement rate, because we all know that inflation and just the cost of doing business continues to go up. And if those reimbursements don't keep pace with that, the provider's ability to hire staff and to make resources available becomes more difficult, and that directly impacts access to care. So these are two rules that we pay attention to very closely. The entire industry does, and we partner with our national partners, the National Rural Health Association, to understand the rule and to, where appropriate, advocate for changes to the rule. And then the final one that we're going to be talking about is the non-discrimination rule. And this we call the Section 1557 rule because in the Affordable Care Act, Section 1557 had to do with non-discrimination. There was many different aspects of that non-discrimination rule. But this is not an annual rule. This is CMS releasing some long-awaited further guidance or regulations to providers and to health plans on how they're expected to implement the 1557 requirements in the Affordable Care Act. Then, as Danae said, we will talk about some ideas of where we think the new administration will go. Although I want to caveat that and say that it's very difficult to predict where this new administration will go. What we did was we took a rational approach where we looked at the past because we have an example of when President Trump was in the first time. We can see the priorities of the administration there. And actually, we just got recent news that Dr. Oz is going to be the director of CMS. And we have Robert F. Kennedy Jr. is going to be the director of HHS. And these are the leading figures that will oversee these rules and how Medicare and how Medicaid are administered going forward. So that'll be very interesting. But we're gonna what we have done is we've analyzed the past to predict the future. The caveat is no, it's hard to predict the future. So let's go into it with that. So with that, Danae, let's move on. And we don't have all day. We could spend all day on these rules. These are hundreds of pages long. And but we did make the opportunity to do 20 minutes today on this. So if anyone feels like, hey, I actually want to learn a lot more about this, or I'm concerned about some issue here, please get in contact with us. We're happy to send you written information. We're happy to meet with you one-on-one to go through this, and really just help our members and help providers across the state understand the impacts of these rules. So with that, let's get into the OPPS rule. So this one is a recent rule. So this was finally finalized on November 1st, 2024. So this is a recent rule, and the purpose of it is to as it says here, I put these slides together to update on payment policies, quality reporting, and the COPs, the conditions of participation. So that's one way that CMS you know ch- uh, administers the OPPS is they are constantly updating the COPs, as most of, not all of you already know that. So going on to the next slide. All right. So what is the high level? So the payment increases here. The high level is a 2.9% increase for outpatient hospitals and a 3.2% increase for rural hospitals. So that's sort of the high level piece, and we know that yeah. So I'm sorry, I see some comments coming through. It's not a decrease, and medical inflation is much higher than the rate of annual inflation. I think regular annual inflation is around 3 or 4% these days, but that's where we're at. That's where the federal government put that out, and you can see some of the other charges here as well. Danae, I don't believe this also impacts IHS. I don't believe that's relevant to this group here, but we did include that because that was part of the rule as well. So moving on, so the OB services, these go into effect January 1st. And, so what we see here is that there's new quality improvement integration with maternal mortality review data that's going to be required on 2027. And then we also see new protocols for OB complications as well. And we can, if folks are interested in exactly what those are, we can send those to you as well. But these are some new OB conditions of participation that we're seeing put forward in the final rule.
And I'll
So
just jump
moving
in. I
on,
know we did
yeah.
listening sessions on these rules, and I know there was concern around additional conditions of participation around OB and things like that. So we'll obviously continue to have conversations with the administration, whoever's in charge as things are rolling through, and with the legislature as they come in. We'll continue to have conversations about where we have concerns on these rules. So as we look
Mhm.
through these and these are now finalized, please continue to let us know how rule changes and how these conditions of participation impact your ability to provide care to your patients and let us know what things are good and what things are not good, so we can continue to bring that message up. So, but I remember this being a very hot topic of conversation in our listening session. So I just wanted to reiterate that we're always listening for you guys. And that's part of what today is, what are the things that are good that we can lift up and, say to CMS, like, keep doing this, and which things are not as helpful as, they might think that they are. And so we can provide some education around what might be a better use of regulation for patient outcomes.
Absolutely. Okay. So with that, I'm just seeing if there's any questions here. Okay. So again, there's some different there are some different effective dates in the rule. And so one of the effective dates here for 2020 for July 1, 2025 are the emergency services readiness. And so here the providers are required to have adequate emergency protocols and staff training by 2025, some annual documentation of training completion, and the quality program findings to inform training updates by July 1, 2025. Okay, so supervision and prior auth. These are always big topics of conversation. So the virtual supervision, this is extended through, and this was a result of pretty intense advocacy, but this was extended through December 31st, 2025, for the services you can see there. And there are some prior auth changes as well, where there's a reduced time frame for outpatient department services from 10 to 7 calendar days. So the plans have to approve the prior auth by, from 10 down to 7 days. So some Medicaid and CHIP updates. They so we have continuous eligibility. So we have 12-month eligibility for children under 19. So if you're eligible for CHIP, and you're eligible in 1 month, then you're eligible for for the next 12 months. And then for the Medicaid clinic services, they did put some exceptions to the four walls requirements for rural clinics and behavioral health clinics. Okay, so quality reporting programs. So we have hospital outpatient quality reporting. So we have some new measures. There's a commitment to health equity. And as CMS says, there's a removal of outdated measures. So, for example, MRA lumbar spine for low back pain. And there's some EHR certification requirements starting in for the 2025 reporting. And then the rural emergency hospital quality reporting. Danae, I don't, the last time we went over the rural emergency hospital designation, I think, said that that was something that didn't appear to be as attractive to our hospitals in the state. Um, is that still the case based on your
Yeah,
conversation with
I think
providers?
broadly, I know we do have one REH in the state now, and I did have a conversation with another facility recently who's interested. Um, So I think it's particularly as they continue to kind of tweak the rule, it may become a better deal for some hospitals that might be struggling or some facilities that previously closed that want to reopen as an REH. So we're continuing to work with NRHAs, doing a lot of advocacy around kind of expanding the eligibility to make it feasible for hospitals that are or formally previously closed hospitals who are interested in that designation.
Right, right, right. Okay. And so, working with our national colleagues, just looking at some opportunities and some challenges. Um, we do have some increased payments and flexibility in rural settings. And there are some quality reporting that focuses on health equity, which is something that the advocates have been pushing for, really looking at the morbidity of the population in rural areas versus urban areas to understand the way that payment works and the way that some other things work. And then the challenges, of course, are, compliance and then, the shorter prior auth times in the reporting metrics. So when we think about a strategic action plan and really looking at what hospitals and what clinics can do. We have the ability to implement and train for new COPs, and that's something we can talk about, with the membership, and then review the quality programs for alignment with the new requirements as well. So really, it's a compliance piece. And then for clinics, we have the ability to leverage exceptions for the Medicaid services and to utilize new payment structures for the preventive and IOP services. Okay. So moving on to the physician fees schedule final rule. And this one was also released November 1st. And again, this relates to payment policies, just like the OPPS rule, but impacting, physician payment and provider payment, telehealth and rural health clinics. So we're going to be going over a few issues, as you can see, payment reductions, care coordination, and new billing requirements. Here we have a decrease. So we have a 2.93% decrease for 2025. And there are legislative efforts moving. Now, Congress doesn't pass as many laws as it used to. So we will see if Congress can get its act together and help to increase the pay for our providers. So for some telehealth updates, audio only is preserved for patients unable to use video. And the direct supervision through audio video is extended through the end of 2025. And for opioid treatment programs, audio only periodic assessments are allowed here. So this is a positive step, and we'll see what the future of telehealth is. But for RHCs and FQHCs, telehealth services again are extended through the end of 2025. And certification requirements are updated to clarify primary care provisions, and conditions for certification expanded to allow for over 50% of specialty and behavioral health care. So you can have over. Danae, remind the group about, because we talked a lot about this, about the requirement of physical health versus mental health care and the difficulty here, and how the new rules will allow for over 50% of behavioral health care.
Yeah, it's been for a long time. The way that it was written and interpreted was primarily engaged in primary care, which really limited, it had to be 50% over 50% of primary care services. And that was causing some issues. And actually, Tracy can probably speak to this as a surveyor. It was causing issues in RHC survey of, if they had too many mental health services, are they not doing primarily primary care? And that's been something that, we've all been advocating for a long time to get rid of that, and really just acknowledge, mental health, behavioral health is part of providing primary care. So that's a big change there for that. So Tracy, I don't know if you want to speak to if you have already started looking at that from a survey perspective.
That is a huge change, because that's an indication that they're starting to recognize the behavioral health crisis essentially we're in, and that loosens up the regulation, specifically encouraging more behavioral health providers in RHCs. So yes, and Kate can speak to that this afternoon, but that's a huge win for the RHC world.
Mm-hmm. So here on the care coordination side, there's a transition from the single code to individual codes, as you can see here, by July 1, 2025. And there are some improvements to payment accuracy services here. And again, this is a much shorter um, overview of this rule than we provided in our, in-depth listening session. And if more information on the rule is needed, we have much longer overviews of these rules.
Yeah, and I'll also say on Monday, NARHC did a really in-depth webinar about this rule and all the changes that impact RHCs. So definitely recommend go back and find that and watch that. And this G0511 is this change is something that NARHC I think advocated for a while. So I know they were happy to see that change.
Mhm. All right, so beginning July 1, 2025, RHCs and FQHCs can bill and receive payment for Part B preventive vaccines at the time of service, which is something that was a big topic of advocacy. And RHCs and FQHCs are allowed to bill for both 3 and 4 day service rates. So for advanced primary services, there are new codes to enable comprehensive care management, and the requirements include beneficiary consent, coordination of care transitions, and performance measurement of care quality. So there are some opportunities and some challenges, and of course, they're going to be different, perhaps for different settings, but obviously, some of the opportunities are to continue to leverage the telehealth extensions, and the challenges are the reduced payment rates. Absolutely. Okay. So moving on to the Section 1557 non-discrimination rule. So this was published on May 15th. So this is less new than the November rules. And this is focused on non-discrimination. So placing requirements on providers and on plans on how they are supposed to implement this, how they're supposed to put processes in place to ensure that discrimination doesn't occur. And it applies to Medicare, Medicaid, and the marketplace plans. So um, entities with 15 or more employees, they must have a coordinator by November 2nd, 2024. So that date has passed us here. And they have responsibilities that you can see here to deal with different issues as it relates to discrimination. So record keeping and grievances and things like that. So there are some written policies that need to be in place. I think you're all, very used to doing written policies on many different things. And as you can see, these written policies must address your non-discrimination policies, language assistance, how to contact the 1557 coordinator, and reasonable modifications for individuals with disabilities. There's new training here. So this can be, I think, lumped into some of your other training that you're doing. So mandatory 1557 training by July 5th, 2025. And new hires must be trained within a reasonable time and maintaining the documentation for 3 years. There's a, notice of non-discrimination, just like all the employment posters that you put up in your break room. So here you notice that needs to be put up. And the notice of translation services in the top 15 languages. So there were new regulations put in place to deal with telehealth AI. So it was intended to mitigate bias in patient care decision and support tools and AI algorithms. So some of that, of course, impacts the health plans as well. But there are policies put in place to reduce the risk of discriminatory outcomes, as CMS puts it. And I know that we're running up against some time here. There's a lot to go over. Are we good, Danae? Yeah, okay. So, discrimination based on sex here. So, clarifies that discrimination includes sex stereotypes, intersex traits, pregnancy, sexual orientation, and gender identity. It does not mandate gender affirming care if religious or clinical exemptions apply. And so, CMS is stating that these regulations are consistent with a Supreme Court ruling. A recent Supreme Court ruling. So, as you can see, here are some of the key deadlines on the basis of this rule. And thinking about opportunities and challenges, so there are some definite opportunities here to create more patient trust, absolutely, to communicate to your patients about your commitment to non-discrimination. And then challenges, I mean, always there's a compliance challenge because the new requirements don't come with, new funding to do the things that the rule asks you to do. So that can be a major challenge. All right. Okay. So let's quickly think about or discuss rather potential President Trump health priorities. And like I said, um, it's difficult to predict things because we don't know what the future holds, but we're in a rare situation because we have a new administration coming in, a new president coming in, and we've already had this president before. So we can make some educated guesses about those healthcare priorities based on what we've seen in the past and what was said in the election season to make a determination about where the focus can be. So one of the things that I think is is a big headline is that President Trump is a supporter of Medicare and Social Security, and so there's a big support for those traditional programs, and I think it's also um, I think it's also a observation to state that the Trump administration was a supporter of Medicare Advantage as well, as bringing the private market solution into Medicare. And so that's something that I think we're going to see his administration support quite a bit. And really, I think, you know, make make the program. Of course, there's been so many criticisms of Medicare Advantage from the provider side. Absolutely. Prior authorization, payment, networks, managed care. I mean, you name it, right? And I think that the administration hears that, but at the same time, the industry is saying, well, this program is a way to, and when I say industry, the health insurance industry on the other end is saying, this is a really cost-effective way to manage this very expensive program. And so if we can make it even more, cost effective, then we can save the government even more money and cover more people. And so we really have seen that in the last administration, where when I say the last administration, the last Trump administration loosened some of the Medicare Advantage regulations to make it easier for the Medicare Advantage plans to operate. So that's a
Yeah.
theme.
Yeah, and I'll just say, we've already been working on, doing a lot of education and advocacy around Medicare Advantage, both LRHA and, all of our the other rural stakeholders, national partners. There's a lot of discussion happening at all levels about Medicare Advantage and the issues that you all are seeing there. So that's all was already on our list as a high priority for education and advocacy with um, the legislators at the state level, but particularly at the federal level. When we go to DC in February, we're going to be talking about Medicare Advantage again. And so that's part of, and we'll talk about in a minute when we talk about the challenges that we saw in the provider survey that we did. We did focus on managed care, and we'll talk about what came through. But it's important for us in our advocacy to continue to hear from you guys what the challenges are with Medicare Advantage, not only kind of big picture and globally and broadly, but also like specific examples that we can then bring to, the administration, to, our representatives and our senators and say like, hey, this is the issue that our, small rural hospitals are trying to provide care and they're running into this issue with Medicare Advantage. So the more we can educate them on what it's looking like, on the ground, the better we can, do in, making sure that they're putting rules in place to do what they need to do to make sure that you guys are protected and the patients are protected. So that's an area we're going to continue to do education and advocacy on.
Yeah, absolutely. Um, so, we're working with our partners at the national level. One of the areas that they've identified is looking at the staffing requirements. Those were a huge burden on, the nurse staffing requirements on certain facilities. So there could be the ability to reverse some of that. Um, so some of these value-based payment models, there could be some changes pursued there at CMS through CMMI. Again, that it just depends on your it really depends on your opinion of some of these value-based models. But I think this is something that the next Trump administration could look into quite a bit. Um, exactly what overhauls to CDC and NIH look like is yet to be seen. I think where the Trump administration will focus on are the grant making through these agencies. What are those agencies that are receiving grants? What are they doing with them? How does it impact healthcare? How does it add to our knowledge and understanding of, infectious disease or of, other major healthcare issues? And then looking at, some of Project 2025, where we, kind of understand where some of the priorities lie. Price transparency is a big piece in there. Site neutrality, that's a big fight. We're seeing that actually across the country at the state level, where, the health plans are, pushing laws that, prohibit the, including the facility fee, right? And so that's going to be, a big fight at both the state and the federal level, I think. Uncompensated care policies and, restructuring the 340B program. I mean, that's a huge program. There's a lot of fighting going on there. Exactly what could be done there is yet to be seen, but this is something that the next administration could look at.
Yeah, and these are also other areas where we've done, particularly the pricing transparency, site neutrality, and the 340B. We've done some advocacy around that. There's a lot of discussion about that. NRHA is working really hard on those. So that's another area that it's important for us to hear your stories and how as potential policies come out, and new bills and things like that, to hear from you guys what the text is actually going to do in real life, so that we can bring that message back up to make sure that as they're looking through these things and potentially changing rules, and putting out bills and things like that, that we're providing that education to make sure that as they're writing them, they know what the changes are going to do, and because restructure 340B could, do a lot of things. So, and there's been a lot of fight about all of those things happening. So we want to make sure that that your voices as rural providers are heard in all of these big conversations that are happening around all of these potential big changes.
All right, well, we tried to go as quickly as we could, 20 minutes. Uh, so if there are questions, I do want to leave time for some of the other topics we had today, but yeah, I'll yield back to you, Danae.
One thing I can comment on is that we know that in his former administration, President Trump was very strong on rural and implemented some rural grants and rural activities that did help. So there's hopefully a positive there, and hopefully that will continue through the next administration.
Yeah, and we do have the Louisiana has the unique position of the Speaker of the House is from here. Representative Scalise is also in a leadership role, and it looks like Senator Cassidy is going to be lead of help as well. So we have a very unique position to have a lot of voice from Louisiana in these leadership roles. And so we continue to leverage that connection there when we go in February and when we continue to build those relationships with our elected officials. And they do, when we go, they do listen, they want to hear stories and from the providers, and they want to know what's going on in your facilities and what you need and what's really going to be helpful and impactful. So that's definitely a win for us, is that we have, kind of the ear of the Speaker of the House and some other folks in leadership in Washington. So that's a really great place for us to be. So continue to be engaged and, know that, they're listening to us. So if we keep telling them what we need, hopefully we can make some movement at the national level. So,
I think that's really going to be important. I'm sorry.
No, go ahead.
I think it's really going to be important to hear from the people on the ground and how that really affects them. So now more than ever, I think we need that input and that real story that's coming from the field to address those advantages we have and to make some impact.
Yeah. And that's, the real individual, like we LRHA come with the data and the information and, all of these things, but it's very different. And you can see in the reaction that it hits really different for the lawmakers and their staff when it's the administrator of the hospital or the clinic manager or whoever is telling the real stories of their patients and their facility and what they're dealing with and what they need. It puts a human face on it, and makes it real for them, what the policies that they're, what the laws and the rule changes and things are really doing. So that's really, really impactful. And then we can come in and back it up with the data and the information and how can you do what the provider's asking you to do. So, again, with the support of, all of our other stakeholder partners, we can come in with that, but, we can't tell that story. It's your story to tell. So we definitely want to, as much as possible, lift up your voices and make sure that your needs are heard. So, so I do want to kind of touch on some challenges that we saw. So we did a rural provider survey recently, and we did have a good number of people respond to that. So if you did respond, thank you very much for that. So one of the questions we asked was where support services are needed. And this was the kind of the ranking of the top 3. So peer networking and best practice sharing. So we are going to lean into that. We're going to touch on that a little bit today. And, if you guys have any best practicing that you can share, there'll be opportunity for that at the end here. And then support around emergency preparedness and response. So that's something we'll be looking into in the coming years. And then education on coding and billing is always an issue. So, we'll continue to work on that as an organization and providing opportunities and support in these three areas. But I don't know, does anyone have any kind of additional comments or want to expound on any of these challenges that you're facing as a rural hospital out in your community? All right, hearing none, we'll move. I think they're fairly self-explanatory.
Addressing number two, please remember that for your RHCs, there is an emergency preparedness template there, and the State Office of Rural Health does do the quarterly emergency drill tabletop for you to bring back to your clinic and give you a certification for that. So, of course, they'll continue to work on that and make it as easy as possible. And definitely, if you have input on how we can make that better, please let us know.
Yeah. And then because we know Medicare Advantage and Medicaid managed care are such big hot topic issues that we hear about a lot from our rural providers, we did have a section in that survey that was specifically about managed care. And so the overall message that we got was that all of it is difficult. It's all a problem, kind of every facet of particularly Medicare Advantage, but even on the MCO side. But this was kind of how the ranking came out in terms of the biggest concerns and the most issues was with prior authorization being like the main concern and the main issue, followed by reimbursement rates, and then the coverage of benefits and network adequacy kind of tied in third place there. So I see someone has unmuted if you want to kind of expound on your Medicare Advantage concerns.
Well, I have to say something at some point just because, I have to vent. But one of the things that's come up lately that I think also needs to be maybe just brought to everybody's attention at the state and the federal level is that the plans really are pushing the envelope now on what they're doing to patients without telling the patients. And so you have patients, some of whom are Medicaid eligible, who are being moved off their Medicaid plans to exchange plans with the same company, and they're not being notified of this. And we've had some patients who were moved off of commercial plans to exchange plans. And, a lot of times they'll end up on the exchange plan. They'll still have Medicaid as their secondary payer, for example, which again is just a sign that the company is double dipping, getting their PM from the state while they're getting their tax, their subsidized premiums from the feds. But they're moving them over to these exchange plans that have deductibles that are anywhere from $5,000 to $8,000. And at the same time, I can tell you from where we are, none of the rural hospitals in this area are in network with this exchange plan. I haven't heard back from some of our brethren to the west or to the south, but the two hospitals to the north are not in network with this plan. So you have patients who are being told they have to go to Monroe just for basic primary care because they don't have an outlet or an access point here locally. And they come in with their Medicaid card and, you run eligibility and you find out, oh, I'm sorry, you've been moved over to this other plan. And this is happening nationally. But I think the thing that keeps getting lost, and we see it every time they come and speak at any of our events and we give them questions, what's being lost on the people at the state and federal level is that the plans do not stop. They are constantly working different angles to make this happen. And until heavily punitive measures are taken, they aren't going to stop. They're going to keep doing as much as they can until somebody draws a line and says, if you keep pushing, you're going to get smacked. And nobody does anything. And so, I know y'all are probably tired and exhausted from me saying it, but until there's punishment, you can have as many rules, as many regulations, as many red lines and strongly worded letters about Medicare Advantage or the MCOs at the state level. Nothing will change. And that's all I was going to say. This is just the latest example of, as long as they can take a mile, they're going to take 5 miles, and they're going to keep coming up with new angles to take 5 miles. So anyway, that's it.
Yeah, no, thank you for that. And I know we've talked about that before. And you're not the only person to bring up that you know, punitive measures is, the rules are in place, but if there's no consequence for not following the rule, then what's the rule for, right? So you're not the only person to say that. So that is definitely noted. Is that Medicare, the moving around, is that a Medicare Advantage or a Medicaid managed care that you're seeing that happen with?
Yeah, the moving around is happening primarily Medicaid to exchange. Somewhat, we're seeing commercial to exchange.
So Blake, when you say commercial to exchange, you're talking about
I'm talking
someone,
about somebody who has a United policy that they pay
yeah,
premiums for, that they get moved to an exchange plan. And initially, they don't complain because now they don't have to pay premiums, and they're happy about that. But then they don't get happy when they actually try to get health care.
right. But you're talking about someone maybe who's on an employer plan and then gets moved to a
We haven't seen it for an
exchange plan.
employer-based plan. This is a single coverage.
Okay, so they're paying full freight for an individual plan, and then they
Right, or
get
a
moved
family
to a
plan. Yeah.
or family plan. Then they get moved to the exchange plan at a zero premium. But now they have the deductible. Now they have a different network. Now they have all these other things, and they don't really understand the impact of that. And so that's the challenge there.
Yes.
Okay. Yeah, that's good to know. And one of the things about that, and I know we don't have a ton more time, is advocating at the federal level is extremely difficult because Congress doesn't do much, and the federal bureaucracies are huge, and there's so many different um, players in that. And of course, we're a part of that, and we help move the ball forward, and there's been a lot of successes. But some of the things, Blake, that you brought up, there are policy levers at the state level that we can discuss as well. And there could be an opportunity for us to, use our voice at the state level to, make things easier for our providers. So it's just something to keep in mind as we move forward.
Yeah, so those types of examples are things that are really helpful for us to kind of know, so we know where to look and what what's happening on the ground, so we can lift up those stories and make sure that we're including those things in our conversations, and where we need to be focusing our advocacy work, again, both at the state and at the federal level. So thank you for that. So again, this was the kind of the spread we saw with Medicare Advantage. A slightly different spread for Medicaid managed care, which was interesting to see in the survey. Prior authorization was still the first issue, so there's apparently a lot of issues around prior auth on both sides. But the rest of the concerns kind of spread out a little bit differently for Medicaid managed care. So coverage of benefits was a big concern, which is something we've been working on of increasing coverage. Network adequacy, which we talk about frequently, and then reimbursement rates as the fourth issue there. So any other kind of comments on challenges generally that you guys are facing? I know we're fairly close on time, but any other things that you guys want to lift up that we haven't talked about in terms of challenges that you just want to commiserate with each other or share with us as an opportunity for LRHA or the State Office of Rural Health to provide support on. All right, hearing none, we will move on. But as always, please feel free to reach out to us if something comes up that we can provide any assistance on at all. Again, both at the Louisiana Rural Health Association and the State Office of Rural Health. Tracy has many years of experience in rural health and is now consulting with the state office. So, we work very closely together to make sure that we're supporting the rural providers across the state however we can. So we will definitely do whatever we can to help you guys. So we have just a few minutes left. If anybody has some exciting wins from this year at your facility, did you make any changes that you're excited about? Did you add a service line or do a new program? Is anybody doing renovations? Anything like that you just wanted to share? We'd love to hear about some good things happening in rural if you have any kind of wins from 2024 that you'd like to share.
I'll chime in to break the ice. I think that behavioral health change and the fact that it's not only behavioral health but specialty also, I think that's a huge win. That's coming up in legislation, and the continuation of the telehealth, because that was so close to possibly being ended. I think that both of those were a good win for 2024 going into 2025.
All right, I see in the chat the state 340B law submitting enforcement requests to the Attorney General today. So a lot of good discussion happened this year around 340B, and hopefully we'll see some good positive movement in the 340B space. I think that's good stuff. I'll say, even though it's we've kind of labeled it as a challenge, but the very broad, robust discussion around Medicare Advantage, I think, was a win. There's a lot of movement. I'm hearing it in pretty much all the meetings that I'm in that talk about, policy, rural health policy. Every other state's facing it. All the federal partners are working on it. So there's a lot of attention and there's a lot of push around Medicare Advantage. So the fact that these challenges are, even though they're challenging, at least, it's kind of, you guys are not alone. It's not a unique, unfortunately, it's not unique to the state, but that also gives, the kind of the power in numbers of that message, hopefully coming together as a big group, will really help to push that message forward as we move into future years. So hopefully we'll get some power in numbers and some movement on the Medicare Advantage. So with just a couple minutes left, does anyone have any big plans, exciting things coming up in 2025? We talked about we have a lot of opportunity in the regulatory in the advocacy space. With all the legislators from Louisiana. We're excited about the opportunity to continue to go to the Hill, do our visits, speak with folks. I've already heard a little bit from some of the staffers. Mike Johnson's office did reach out and to just kind of touch base, and the folks that we met with last year are still there. So that's a big win for us, is that we know personally some of the staffers that are still there, because those folks do tend to turn over, and it makes it harder to kind of keep connection. So that is a win for us moving into 2025, that we do have that relationship with the staff there to continue to build that trust and build that communication with them, so that we can have more. We can be heard more easily as we're bringing your voices forward. So we're excited about that.
And I will say that apparently one of our hospitals invited Mike Johnson to visit their hospital, and they showed up. and visited the hospital on site. So
Yeah,
that's
yeah, I'll name drop. Diane Davidson Union General Hospital. Actually when we were in DC, we met with Mike Johnson and his staff last year or this year, early this year. And she the way she says it, she just kind of mentioned is like, hey, if he's, because she's in his district, her hospital's in the district, and if he's in town and wants to come by, and they were able to make it happen, and he came on site and did a tour and met with the leadership and all of that stuff. And so I know that was really exciting to be able to, have Mike Johnson in their facility and really show him, the work that they're doing, and put faces to the work and everything that we're talking about in DC. So that's really exciting, and I think there's a lot more opportunity for that. For your representatives from your areas to come and tour your facility and learn about what you're doing and really see firsthand the important work that you guys are doing out in your rural communities.
one more thing. I would be remiss if I wouldn't mention the 2 o'clock meeting for RHCs this afternoon. And the intention there is that it will be quarterly, but we're kind of on a sped up schedule. So we'll be doing it every couple of months until we get to the big Rural Health Conference in June. We're going to give updates, speaking to the list from the expert and asking questions to the experts, and giving some chance for networking. So that will be starting this afternoon at 2 o'clock.
Yeah, so I just popped the registration link for that in the chat. So that's at 2 o'clock today. Tracy will be leading that through with the State Office of Rural Health, and we'll be on board providing some updates and supporting co-hosting that. This recording will be on our website within the next few days, along with the slides, so you guys can kind of look through those. And, as always, please feel free to reach out to us if we can provide any support, any help. If you've got additional information for us about, the work that you're doing, we love to hear not only about the challenges so that we can try to help address those and lift those up, but also the great work that you're doing. If we can highlight that, we'd love to be able to do that. As it's National Rural Health Day, we'll be, checking all the social medias. If you, post some pictures of your staff, of your facility, of the things that you're doing, with the hashtag National Rural Health Day or hashtag Power of Rural, we will like and share and, lift up all of the great work that you're doing. So with that, any final questions before we close for today? All right. Well, great. We are right at time. So thanks again for joining us. Happy National Rural Health Day, and we will talk to you soon.
Thank you.